Hello everybody, welcome to RAAONLINE. I'm Dr. Abinaya, I'm a consultant pediatrician and you are listening to the video lectures in the chapter on neonatology, and this lecture is going to be on infant of diabetic mother, and I have not just restricted to IDM's management but I have included the hypoglycemia protocol also. So let's get started. And we're all very familiar with any type of diabetes like type 1, type 2 or gestational diabetes definitely increase the risk of complications in the mother and in the baby. So it can be any type of diabetes. So this is something that we come across when the expectant couple is referred to the pediatrician or to the neonatologist to counsel the couple about the complications. So it is not about what type of diabetes. Rather, it is about the control of blood sugar and the tight glycemic control really. The complications are more in pre-gestational diabetes. The mother had type 1 diabetes or type 2 just before her pregnancy. It depends on the pre-gestational diabetes. So, it's little bit higher severity or higher risk of complications exist in pre-gestational, but gestational diabetes is something that can cause complications also, and the outcomes depend on how severe the maternal hyperglycemia was. We always counsel the expectant mother to have a tight glycemic control, and we expect that the mother has or maintains a HbA1c of less than 7% in the first trimester where the organogenesis happens, and usually not because of diabetes, gestational or pre-gestational diabetes. Mother can have associated risk factors also. It is not confined only the diabetes, but mothers can have preeclampsia, can have polyhydramnios or risk of preterm labor also. I mean, what actually kickstarts complications is that when there is a hyperglycemic condition in the mother, it causes hyperinsulinism like state. So, when the insulin increases in the serum of the fetus, it is an anabolic hormone. So, it increases the tissues, it increases organs weight and it increases the metabolism. So, around 50%, you can remember as somewhere 45% of the infants of diabetic mother are large for gestational age. So, what about the remaining? Say 45 to 50% is large for gestational age. But what about the remaining? Remaining can be of normal weight. But if the mother has, along with diabetes mellitus, is associated with a vascular disease, say because of the uncontrolled diabetes, it is a microvascular complication is there, then there will be an uteroplacental insufficiency. So, the fetus will have an IUGR like state. So, that is also positive. So, that is also possible. And so, remember, in infant of diabetic mother, not necessary that all the babies, that is 100% of IDM babies need not be large for gestational age. Normal weight is possible, IUGR is also possible, more so when the mother has an associated vascular disease. And uncontrolled maternal diabetes, especially in the first trimester, can lead to recurrent miscarriages. So, fetal loss is also possible. And neonatal mortality, especially, so immediate first 28 days of life, the mortality is also higher in infants who are born to diabetic mothers. All these are important because we need to counsel the couple, right? So, let's get started with the pathophysiology. So, I told you what happens when the mother has an excessive glucose levels in the blood. There is a maternal hyperglycemia, isn't it? So, there is a maternal hyperglycemia. Okay, so the glucose will cross the placenta in response to the glucose, that is the glucose from the mother goes to the fetus. So, fetus will have an hyperglycemia. So, in response to that, what happens? The baby or the fetus's pancreas will secrete insulin. So, more and more glucose, more and more insulin will get secreted. So, that results in fetal hyperinsulinemia. Insulin actually builds up the organs, increases the weight of the tissues, the placenta becomes large, the infant organs are all increasing in weight except for one organ, which is the brain, right? So, all the organs, all the tissues are increasing in their weight except for one organ, which is the brain. And so much of insulin is there, so much of glucose is there. So, what happens? This will increase the glucose uptake in the liver. So, liver gets enlarged and there is accelerated lipogenesis. So, this excessive glucose will be taken up for other metabolisms. So there is excessive of lipogenesis taking place, protein is synthesized. So all these are taking place simultaneously, so which increases the size of the baby. And what happens when the delivery happens? So there is active transport of glucose going on from the mother to the fetus through the placenta. So when the baby is delivered, the placenta is removed. What happens? It interrupts the glucose going from the mother to the fetus, isn't it? So there is transport through the placenta. Placenta is cut, the glucose is withdrawn. But what happens? There is continued insulin secretion in the newborn baby. So that hyperinsulinism will go on. So what happens? There is a risk of hypoglycemia without any glucose, additional glucose that you're giving in. If the baby is not fed well and not adequately fed, what happens? Because of the excessive insulin, so this will cause hypoglycemia. So that is why there is an increased risk of hypoglycemia in these infants. So just take a look here. Separation of the placenta at birth suddenly interrupts the glucose infusion into the neonate, but there is not a proportional effect on the hyperinsulinism. So what happens is this insulin is not sensed well, so continuous, even though there is no glucose, insulin keeps on secreting, so that will lead to hypoglycemia in the first few hours of birth. So that's why blood glucose screening is very essential for infants of diabetic mothers, and I'll tell you what is the frequency of interval in which we have to keep the sugar monitored. So this is the pathophysiology in short. So because of the hyperinsulinism in the fetus, which is extending to the newborn baby, and apart from the hyperinsulinism, what happens? Once we don't give the glucose, this hyperinsulinism is going to result in hypoglycemia. The one more important pathophysiology is that in these infants of diabetic mothers, in response to consistent or persistent hypoglycemia, even the epinephrine and the glucagon response is also diminished. So what happens usually when we in resistant or in refractory hypoglycemias, we try with glucagon, isn't it? Even that is going to be diminished, and this response is seen both in large for gestational age and in IUGR babies born to diabetic mothers. So this is again a flow chart, and so this in short will explain what all the complications you will be anticipating in an infant of diabetic mother. So the starting point here is maternal hyperglycemia. So the mother has high sugar levels, it is passed on. You might ask me one question, what about the insulin in the mother? The mother will have insulin resistance in type 2 and decreased insulin. So this insulin is not going to pass through the placenta, and even if you give exogenous insulin to the mother, like for the control of glucose, the exogenous insulin is also not going to cross the placenta and come to the fetus. So only there is a glucose transport actively done. So this fetal hyperglycemia, we dealt with this part little just prior, isn't it? So the fetal hyperglycemia will cause fetal hyperinsulinemia, and this insulin level is going to cause macrosomia. And because the baby is weak, the complications like birth asphyxia will be there, birth trauma will be there. There is many systemic complications. I'll tell about all the systemic complications. But for now, you can just remember in CVS, there is cardiomyopathy. In respiratory system, there is RDS. RDS is predominantly because the excessive insulin levels and the hypoglycemia itself will prevent or will degrade the surfactant. So there will be a relative surfactant deficiency in these babies, even though they are born at term. And there can be TTN also. And liver metabolism is immature, so these babies will have a prolonged jaundice, and metabolic complications like hypoglycemia, hypocalcemia, polycythemia will be present in these children, and of course hypoxia secondary to birth asphyxia. So all these can result. If the pre-gestational diabetes was there and if the mother didn't have good glycemic control, then that could result in congenital anomalies. We will be talking about from head to toe what all the congenital anomalies that can be seen in IDM. And of course, I told you if there is an that can be an early growth abnormalities can result in miscarriages also. Yeah, most of it we have discussed already. Yeah, so clinical manifestation. So you are called for resuscitation of a baby and the mother is a diabetic. So what all you should expect? So first in prior to the resuscitation. So the 3 questions that you ask, all these things, and prepare for the resuscitation, because if you know the antenatal details, say like what was the estimated fetal weight in the like very last scan, and how was the amniotic fluid, and any other complications during the scans, during the antenatal scan. So sometimes radiologists pick up these congenital anomalies in the antenatal scan. So all the information necessary should have been picked up just prior to your resuscitation. Go through the mother's case sheet completely and be prepared, because if it is a large baby, then there could be, say in case of a vaginal delivery, there can be shoulder dystocia, and because of that the baby can suffer peripartum asphyxia. So be prepared with your team, brief the team of what you're going to expect. Right, and injuries are quite common in these babies. So brachial plexus injury, so immediately after the birth it might not be apparent, so it becomes apparent like at the end of the day 1 or day 2. So keep examining the baby, look for any injuries. There can be sometimes even the facial palsies can be there, brachial plexus injury, clavicle fractures can be possible. So thorough examination is very, very important. And so the first thing is we are worried about is hypoglycemia, and the incidence of hypoglycemia varies quite a bit. Like if the mother had a pre-gestational diabetes, around 50% of the infants, so 25 to maximum 50% of the infants will definitely go for hypoglycemia. If it is a gestational diabetes, it is 1 in 4, that is 25% of the infants of mothers will have hypoglycemia. Again, all these incidences are important, because sometimes as residents you will find, okay, so many percentages, I am very confused. So put it into practice. It is always just imagine how you are going to counsel the mother, or how you are going to counsel the family practically. Because when you say numbers, I believe in my practice also, I believe it gives a lot of confidence in yourself. They are more likely to expect the kind of treatment that the baby is going to receive. If you're not going to tell like, okay, the baby might have hypoglycemia or might not, we will wait and see. So that kind of information is like half-baked information that the family is very unlikely to believe also. So always tell, say 50% chances that baby will go for hypoglycemia. So we will keep taking the blood samples. Otherwise, no, for newborns, especially when you go repeatedly and keep sampling, the family becomes very anxious. And you have to tell them, so definitely 50% will have. So we will keep checking. We are only going to do the screening, and adequate feeding is necessary. So they'll be extra cautious. They'll keep feeding. They'll come back to you and tell, doctor, we fed now. When are we going to take the next sample? So always take these percentages, very basic ones only. I'm telling all in my presentations, not the complex ones. So imagine how you're going to counsel the family. In that way, we can remember for a long term, not just for the examinations, but for a long term in your practice also you will remember, right? So hypoglycemia, I told you 50% for pre-gestational and 25% for gestational diabetes, right? But is the baby going to be symptomatic? A tiny bit. Say severe hypoglycemia, less than 25 milligram per deciliter, the sugar has dropped, only then the jitters, seizures, or very drowsy baby. So all these symptoms can come only if the blood sugar is going to drop very less, and most of them are asymptomatic. And usually the dip, the maximum nadir is going to be reached after 1 hour, say 1 to 3 hours of it. So this is when we have to be very, very careful and make sure the baby is fed well. And the hypoglycemia in infants of diabetic mothers can persist for 72 hours. So the first 2-3 days, it's very, very important. Tell them that the baby cannot be discharged for day 3, and we'll keep monitoring the blood sugar. And sometimes it can last even up to 7 days when there is an hyperinsulinemic state which is persisting. So we'll talk about it in this presentation towards the end. Okay, so these are all small things, but will help you in a long way. So in one of my previous slides, I told you, so it's not about only fetal hyperinsulinemia, but the babies, once they're born, the newborn mortality and morbidity is going to be increased. And there are variety of factors that will increase the mortality and morbidity in these infants. And we will see system-wise so that it is easy for you to remember. So first thing is congenital anomalies. Congenital anomalies is, it's more common in pre-gestational diabetes or in gestational diabetes, where the initial first trimester maternal glucose is not under control. Okay, so first thing is congenital anomalies. Next, I think we'll start from, yeah. So I have one more picture for you, one more image for you to, I'll show you, but this is taken from the Nelson textbooks. I didn't want to skip this. Right, okay. So we'll start from the metabolic complications, I would say. Polycythemia also can be included here. Right. So first is the metabolic complications. Neonatal jaundice, hypoglycemia, hypocalcemia, hypomagnesemia, and polycythemia. So these are all metabolic complications. Next, coming to the cardiovascular system. So there is risk of heart failure, asymmetrical septal hypertrophy, which we have seen, and I will show you some of the congenital heart diseases which are common in IDM a little later. And this is about the respiratory system complications, surfactant deficiency, transient tachypnea of newborn, like surfactant deficiency causing RDS and TTN. These are the most common things. Persistent pulmonary hypertension in a minor percentage. And GIT. Okay, so GIT is lazy left colon is one of the congenital anomaly, and that can be persistent, and after that there can be visceromegaly. So this is also included in GIT. Hepatosplenomegaly can be there, renomegaly can be there in these infants, and for renal vein thrombosis secondary to polycythemia is also possible. So it doesn't stop here. And of course, birth defects I have told already. So it doesn't stop here. The one thing is IDM babies have to be kept under follow-up with the with the goal that this diabetes or this fetal hyperglycemia and fetal hyperinsulinemia can progress to obesity in their childhood, in their teenage years. So keep them under follow-up. So later life obesity, diabetes with insulin resistance is possible in these infants. So that also has to be kept in mind and counseled to the family. So this is a infant of diabetic mother. Images taken from the Nelson textbook. So I think maximum we have discussed already. Here I am just presenting the clinical features only. So metabolic complications I told you, even hypoglycemia, even in severe hypoglycemia only the babies go for that symptomatic presentation. So when it is symptomatic hypoglycemia, babies become very jittery, they become very tremulous and hyper excitable. So all these will be present in the first 3 days where hypoglycemia is common. And severe hypoglycemia, babies can go even for lethargy, no feeding, poor feeding, hypotonia, and polycythemia is also common. Respiratory system, we know it is RDS and TTN. So presentation of RDS like tachypnea, increased work of breathing, all this has to be checked for. And RDS, because of the fetal hyperinsulinemia that inhibits the surfactant production and or the expression of the surfactant protein. That is why RDS is more common in infants of diabetic mothers. So CVS, we just discussed the asymmetrical septal hypertrophy. CCF in 5 to 10% of the infants, and apart from that there can be subaortic stenosis. So this is actually a transient phenomenon seen in IDM, and this is an idiopathic phenomenon because of the hypertrophied subaortic bundle, and the treatment is with beta blockers to relieve the obstruction. Renal, we just mentioned that renal vein thrombosis secondary to polycythemia is common. So the clinical feature is the baby can have a hematuria or a flank mass, and sometimes it can present as, if it is bilateral renal vein thrombosis, there can be thrombocytopenia also. So coming to the CNS complications or the CNS manifestations, acute neurological manifestations, we know lethargy, poor feeding, jitteriness, tremulousness, seizures, all these things. But as a part of the congenital anomaly, there can be a caudal regression syndrome or a caudal dysplasia sequence. So this is also seen in IDM. Coming back to the congenital malformations. So I want you to recall the first slide. So I told you pre-gestational diabetic mothers have a higher risk of having congenital malformations in their babies, isn't it? So how many folds? 4 folds. So there is a 4-fold increase in the congenital anomalies in infants who are born to mothers with pre-gestational diabetes, and the risk very much depends on HbA1c, very important, and pre-conceptual we aim for HbA1c less than 6.5, and in the first trimester at least it should be less than 7%. And apart from CVS, I told you certain anomalies. So apart from that, even TGA, left to right shunt anomalies, hypoplastic left heart, coarctation of aorta are also common. Asymmetrical septal hypertrophy, cardiac failure, and the subaortic stenosis, those are all quite common. And apart from these or some left to right lesions are also seen in these IDM babies. So caudal regression or the caudal dysplasia sequence is what I told you. And apart from this, even neural tube defects are seen in IDM babies. So this is again a very interesting picture from Elsevier journal, and so here everything about the IDM baby, the clinical features or the complications have been mentioned along with the percentages. I would like you to take 2 minutes and go through this images. So I think one or two I have missed here. So one is this renal anomalies, especially hypospadias and obstructive urinary anomalies. So it has been missed in the previous thing, and other things, I think everything has been mentioned here. So go through this image, and this is not from Nelson but another journal only, and so you have a like complete idea from top to bottom. So you can even take notes like in CNS what are the clinical features, in birth injuries, next coming to the birth injuries, next come to cardiac, respiratory, limbs, any problem like limb defects and clavicle injuries, etc., GIT, liver, renal, metabolic complications, and any other miscellaneous complications. So you can just put from head to toe what are the complications, and you can make a note of yourself, right? So I hope you have gone through this. Let's move further. So coming to the preventive treatment. So the preventive aspect, we cannot, I mean, this is something that has to be dealt by the obstetricians, and the prevention is like to have a tight glycemic control by the mother preconceptionally. So that is very important. So the preconceptional glucose control itself is very important, and once the baby is born, right from the resuscitation, and the first 72 hours is very crucial for any metabolic complication, any other risk we have to keep monitoring. So the I told you the glucose reaches another at 1 to 3 hours of life, isn't it? So this is the time where you have to be extra cautious, and all babies who are born to diabetic mothers should be initiated feeding in the golden hour. So this golden hour, I think it is universally we are practicing. Sometimes it gets missed also. 1 hour later or 1.5 hours later only the baby is fed, but especially in IDMs, you have to initiate feeding within that first 1 hour. So that is very, very important. And we do take at 30 minutes, we do take the glucose levels. So start from there. And the blood glucose monitoring, I think there are certain, I mean, in the Nelson there is one protocol, and other there is an AIMS protocol, and one other guideline from IAP. So the values are little bit different. So some papers do mention 40, some papers do mention 45. So I want you to stick to one protocol. It is easier for you to remember and do it practically also, right? So I will talk about the protocols a little later. So some fewer things, some new methods I wanted to describe before moving on to the protocol. So one thing is this dextrose gel. Okay, so this is I have an image. So this dextrose gel, basically it's a quick remedy even if you don't have a Venflon, if the baby doesn't have an IV line. So if you find that the baby has hypoglycemia and you have given a feed, and or if even before you give a feed, like the baby is not sucking, you want to put a gavage feed, and so it takes time, right? So this is something very quickly it can be done. So these are all ready-made dextrose gels which are squeezed and given to the baby in the buccal area, and they have this dosages based upon the birth weight, and so it is squeezed in the syringe, and before giving the dextrose gel into the buccal cavity, you dry it by just putting a gauze and scooping it inside, and then place the dextrose gel in the inner surface of the cheeks, and once you place it, just massage it well so that it gets absorbed readily, and you have to give a complete dose at a time. So this is something newer concept, and feeding, of course, it depends on what kind of, I mean, the clinical scenario at that time. Always establish a feed. If the baby is not able to feed, put a nasogastric tube, give the breast milk, or if the breast milk is not available, give the formula. And next is dextrose gel. If the baby is symptomatic or if the baby is not responsive to the oral feeds, only then you have to start IV glucose. Initially, we start with the bolus, 10% dextrose, and then we start with the, along with, after giving the bolus, immediately your next step is to start the glucose infusion rate and keep monitoring the blood glucose levels. So this is from Nelson textbook, and more or less it is similar to what we practice, just I found a little bit of the values have changed. So I'm going to discuss it a little later, and yeah, so I will discuss the hypoglycemia protocol here. Okay. So let's get started. Again, this hypoglycemia, I told you the normal range of blood glucose is variable. In many protocols it is variable, and again operational threshold is defined by consensus only. So we have decided to keep the blood glucose to 40. This is the operational threshold defined by AAP. WHO defines hypoglycemia as 45. Okay, I think most of the Indian protocols also have 45 only. So, hypoglycemia is blood glucose level less than 45 milligram per deciliter. So, these are all the indications for routine blood glucose screening. I'm sure all of you are doing it. And this is a tabular column which tells how frequently you have to check the blood glucose levels. So, the at-risk neonates are given in the previous table. And apart from that, the sick neonates, neonates on parenteral nutrition, and little bit of changes are there, how you are going to frequently monitor. So, first initially for at-risk neonates, we start at birth, that is 0 to 2 hours. Usually we do start at 30 minutes, then 1 hour, and then go to 2 hours. Okay. So, 30 minutes, 1 hour and 2 hours, and then every 6 hours till 24 hours, and then so starting from 30 minutes, 1 hour, and then you keep doing it every 6 hours. This is every 6 hour monitoring is only if the glucose is normal, and we do the measurement of glucose or the checking of glucose is pre-feed always, remember that. And in case if you find at any time there is hypoglycemia, it is not about 6 hour feed, it will be like every pre-hour feed only. So you have to customize it. And sick neonates, it is done every 6 hours to 8 hours, and up to 72 hours we have to be careful, right? So mostly within the first 1 day, usually you will find out, you will pick up babies who are at risk of hypoglycemia, and then individualize to the babies glucose monitoring and how their hypoglycemia levels are and how are they responding to the feeds, or if they are in GIR. If the baby is on total parenteral nutrition, it is done every 6 hours till 72 hours and then once a day. So this is something we do follow, but of course, if the baby is again going in for resistant hypoglycemia or refractory to the GIR, increase the GIR to 12, and that needs a frequent glucose monitoring. That is a very low percentage of babies who go in for such situations. So hypoglycemia symptoms, again, especially in newborns, sometimes most of the time they are asymptomatic, and only by your routine screening you would find out. And the symptoms of hypoglycemia are usually neurogenic symptoms and neuroglycopenic symptoms. Neurogenic are nothing but the autonomic symptoms. So these autonomic symptoms are the ones which causes the jitteriness or the tremulousness, etc., and they will appear sometimes when you feel for the peripheries, they appear very cold. They are in a situation of cold stress. So because of the peripheral vasoconstriction, so it could be autonomic. Neuroglycopenic symptoms are the glucose to the brain, the supply to the brain is decreased. That is neuroglycopenic symptoms. So sudden presentation with seizures or just with apnea, apneic spells, or with a very weak cry, baby is not at all responding, and very shallow breathing, or baby has some distress. So all these are probable, all these are possible, and they are quite common. Very rarely sudden pallor, even arrest, so bradycardia and then arrest. So these are all very rare symptoms. So hypoglycemia can be asymptomatic and symptomatic. So this is the protocol that we most of the time follow. So we will run through this. Okay. So you have measured the blood glucose level. If it is less than 40, so you get blood glucose level less than 40. So 40 or 45, it is still fine. You can use any of the levels and look for the symptoms. If there are symptoms, your protocol will change. If the baby is completely asymptomatic, your protocol is going to change. So if the baby is symptomatic, say there is some jitteriness, tremulousness, or the baby has presented to you with seizures, immediately here there is no wait and watch for IV. Immediately you give a bolus, 10% dextrose, 2 ml per kg. So you have to start with the bolus. Once you have given the bolus, you are not stopping right there. You have to start your GIR, that is glucose infusion at 6 mg per kg per minute. So GIR at 6 it is started, and then monitor the baby every hour. Every hour glucose is monitored, and in case it is okay, like the blood glucose is maintained more than 50, you continue the GIR for 24 hours, and then you come down on the GIR, like every 6 hours you come down on 2 mg per kg per minute. So in case the baby is on GIR 6, so every 6 hours come down on 2. So GIR 4, GIR 2. Mostly we stop at GIR 4 or even at GIR 4 we do stop if the infant is stable and the infant is on oral feeds. And if the blood sugar level on GIR 6, if it is still less than 50, then increase the glucose infusion to 2 mg per kg per minute higher. Increase it to GIR 8. Then you check every hourly. You can keep increasing it up to 12 mg per kg per minute. But at this moment, so when you start increasing your GIR, always go for a central line. And at this moment, if even up to GIR 12, the baby is not at all maintaining the blood sugar levels, then it is the time to take endocrinologist opinion. And also you have to just not depend on GIR anymore. You can give hydrocortisone, get diazoxide or get glucagon and octreotide. So these are all other measures for resistant hypoglycemia. Say this is for symptomatic hypoglycemia. Asymptomatic, say the blood sugar is less than 40 or 45 and the baby is completely asymptomatic. Look at the blood glucose level. If it is less than 20, here again, no, you should not wait, you have to go for IV. If it is between 20 to 40 and then the baby is asymptomatic, first give an oral feed, or you can try a dextrose gel also if it is available. And if the oral feed is given, do check the blood sugar after 1 hour. If the blood sugar level is more than 40, keep giving feeds frequently, monitor the blood sugar. Here you can monitor every 6 hourly for the first 2 days, that is 24 to 48 hours. And you can stop the monitoring after 48 hours. Mostly up to 72 hours, the glucose monitoring will be needed. Again, this is individualized. If the blood glucose level, after you have given one feed, do the blood glucose level after 1 hour, and still if the baby has less than 40, you start giving IV glucose bolus and then start the glucose infusion rate. Okay. So this is just an overview of it. Sometimes we keep increasing the GIR if the baby has symptoms in between also. So that is totally individualized protocol, but you have to follow this generally. And refractory or recurrent hypoglycemia is what I told you already. It is a state where there is hyperinsulinism. Okay, most of the time we have to exclude hyperinsulinism in such instances, and this is when you have to think that when the GIR is also high, like GIR you have reached up to 12 mg per kg per minute, and if it is beyond 1 week, if the baby has hypoglycemic episodes on and off, then definitely you have to rule out insulinemic states. And hyperinsulinemia, again, it is not only in infants of diabetic mothers, but there are many other conditions also, like some genetic defects, receptor defects. So it can be congenital. So these are defects where the insulin secretion is not regulated, right? So we will talk about 2 or 3 conditions. I'll just give a description of 2 or 3. And so congenital is mostly genetic defects. Acquired is of course IDM, infants of diabetic mothers will have a hyperinsulinemic state. IUGR will have, so common is, first common is IDM, second is IUGR, babies have hyperinsulinism, and birth asphyxia, RH incompatibility. So these 4 conditions are quite common. Apart from this, even polycythemia, other congenital conditions like Beckwith-Weidemann syndrome. So these are all hyperinsulinemic conditions, right? So in recurrent or refractory hypoglycemia, we have to rule out hyperinsulinism. So we will be doing a serum insulin levels, right? So we are not just going to do the serum insulin levels, but we will be drawing a sample called as a critical sample. So what is this critical sample is when the baby has hypoglycemia, it is that time we have to draw the critical sample and send for all these, right? So glucose, of course, you know what will be the sugar level at that moment. Next is insulin, serum cortisol levels and serum beta hydroxybutyrate, right? This is serum levels and free fatty acid. So this 4, so apart from glucose, insulin, cortisol, beta hydroxybutyrate and free fatty acid. So these has to be taken. during the hypoglycemia episode, okay, not when you have corrected. So, if you have insulin levels more than 2 milliunits per liter, it is hyperinsulinism. And low free fatty acid levels less than 1.5, low ketones, and so these are all the lab reports, right? So, these three along with an hypoglycemia will tell you that the baby has hyperinsulinism. So, you will come to a diagnosis of hyperinsulinism based on these values. And you can give an IV glucagon, okay, 0.1 mg per kg at the time of hypoglycemia, and then you can take the blood glucose levels. Normally it has to rise, right? But in hyperinsulinism, the glucagon response will be inappropriate. It will not increase the sugar levels. So, it will be low. So, this is the criteria to diagnose hyperinsulinism. Why hyperinsulinism we are stressing is, this is the most common cause for recurrent or refractory hypoglycemia. Okay. And for hyperinsulinism, we have so many conditions. But you have to diagnose it, and then you have to check what has caused that hyperinsulinism and treat the underlying condition. Okay. You got it? So, hyperinsulinism criteria is this, and you have to take 4 values: insulin levels, cortisol levels, the ketones, beta hydroxybutyrate, and the free fatty acids. So, this is the criteria. So, please have this as a reference. And these are the important causes. So, I have just mentioned about the hyperinsulinemic states. So, here I have mentioned few conditions which are causing hyperinsulinism, and some conditions with normal insulin levels but which are causing refractory hypoglycemia are also mentioned here. So, first look at this row over here. So, this is hypoglycemia secondary to hyperinsulinism. Most of these are congenital conditions, and some of them are genetic defects like potassium ATP channel defect, glutamate dehydrogenase defects, short chain hydroxyacyl CoA dehydrogenase mutation. So, these are all genetic defects, and Beckwith-Wiedemann syndrome will have hyperinsulinemic state. Insulin level is normal, but there is hypoglycemia. First, rule out endocrine disorders. Okay, so most of the endocrine disorders you have to rule out. So, what are the endocrine disorders which will cause hypoglycemia? So, one is congenital adrenal hyperplasia. Next is hypopituitarism, that is central cause. Then hypopituitarism can be like panhypopituitarism, or there can be standalone growth hormone deficiency. Okay. So, first rule out endocrine causes if the insulin level is normal but there is continued hypoglycemia, right. Next is IAMs, inborn error of metabolism. So, I have a presentation on approach to IAMs, and subsequently I have planned for a discussion on metabolic disorders separately also. So, here I am just mentioning few metabolic disorders which have a presentation as hypoglycemia also. So, of course, glycogen storage disorders will present with hypoglycemia, gluconeogenesis disorders, fatty acid oxidation defects, some organic acidurias, galactosemia. When the baby started with breastfeeding, day 2, day 3, baby lands up with jaundice and hypoglycemia, hereditary fructose intolerance. So, these are some of the metabolic disorders which will have hypoglycemia. Okay. So, if you get a baby with hypoglycemia and you start your management, meanwhile, if the baby is not responding to your high levels of GIR, you have to think of a refractory or recurrent hypoglycemia. If it is refractory, think of 2 things. It can be hyperinsulinemic or normoinsulinemic. For hyperinsulinemic, just this criteria you have to know. To diagnose hyperinsulinism, all these 4 values here. Okay, so all these 4 values you have to take. So, draw a critical sample and do these 4 values. When you get the report, check with this table if it is hyperinsulinism or not. If it is hyperinsulinism, please go for the genetic condition if there is no apparent condition. Hyperinsulinism, I told you, can be present in IDM, can be present in IUGR, can be present in birth asphyxia. So, if there is no clinically apparent disease, do go ahead with a genetic mutation after discussion with the family. If the insulin level is normal, first rule out endocrine causes and then go in for metabolic causes. Metabolic disorders is now we can do TMS, urine GCMS and liquid chromatography. So, all these they have made our work quite easier. So, even in 24 to 36 hours we do get the samples, we do get the reports, right. So, this is how you have to have a mental framework, and yeah, I think mostly. So, all these, so first few things are for the hyperinsulinism level, and these are for the metabolic condition. So I will discuss this in my IEM approach video. So once we have reached the peak GIR of 12, and we have to go with next level of treatment. So we give hydrocortisone 10 mg per kg per day BD. Hydrocortisone, it increases the gluconeogenesis and it reduces the peripheral utilization of glucose, right? And it can also kickstart the glucagon's effect. So hydrocortisone is quite effective in these babies. Next is diazoxide, octreotide and glucagon. So anything can be taken. It is the unit's choice, and most of them have a set protocol, especially in tertiary hospitals. So diazoxide is a potassium channel agonist and it can be given orally. Octreotide is usually given subcutaneously. It is a somatostatin analog. It inhibits the insulin secretion. Glucagon, again we know it will cause glycogenolysis and increases the gluconeogenesis. So these are all the treatment options in resistant hypoglycemia. Okay. So why are we concerned more about hypoglycemia is that it has a long-term neurodevelopmental outcome issues. So any baby who has a resistant hypoglycemia or a very early hypoglycemia not treated, they can have growth abnormalities, neurodevelopmental problems, vision abnormality, especially the occipital cortex is affected when there is resistant hypoglycemia, even hearing loss. There has been many papers which has done extensive work about neonatal hypoglycemia. So this particular paper, they had studied up to 4.5 years and they found out that so there was visual motor function and poor executive function. Academically, the babies didn't do well, these children. If there was an hypoglycemic injury that you suspect, say the baby had very low glucose levels and you went up to very high GIRs, then you have to definitely plan for a neuroimaging at 4 to 6 weeks, okay? And you have to look for any hypoglycemic injury, right? So in the follow-up, this also has to be planned, right? So we have come to the end of this discussion and I have discussed about IDM. IDM is asked in theory exams. And hypoglycemia management, of course, is something that we need to be thorough practically. And if you have any doubts, any clarifications you want, you can write to us or call us. So I'll meet you in the next video lecture. Thank you everybody for your patient listening.